for joining us. We have Mwembeshi, St. Luke's, Railway, Mazabuka, Andola, Senanga, Petauke, Libuyu, Sichili, Nyimba District, Choma, and we have a lot of people joining us individually. Today, we are going to talk about multi-drug resistant tuberculosis. It will mostly be an introduction because it's quite a heavy subject, so we are going to take it in bits and pieces. But before I go into introducing our presenter today, who's Dr. Patrick Lungu, he's with us at the Ministry of Health. He's the National TB Program Manager. Here in the hub, I'm joined by Sister Makupe, who's our coordinator, Chatonda, and we have a lot of students, our HNP students here at UTH, and we have a special guest here, Chileshe, who's one of the HNB students who's agreed to sit with me, who allows Sister Makupe to give a recap. As we did last week, I'm sure you know that Zambia has gone into breakouts because we have overwhelmed the system. So to encourage more discussion, we'll break into three and discuss the case, then come back where our expert, Dr. Lungu, will summarize the recommendations.
Last week's echo session was on skin conditions in HIV-infected individuals. Skin conditions are common among HIV-infected individuals and may be more prevalent and severe. Therefore, initiation of ART is an important aspect of managing skin conditions in people living with HIV. Identification of characteristic primary lesions is cardinal in diagnosis of skin conditions in people living with HIV. Thank you.
Thank you so much, Sister Makupe. Dr. Lungu, you can go into your presentation. Maybe you want to start with a brief introduction.
Yeah, good afternoon, everyone. I would like to welcome you to today's session, which is on drug-resistant TB. As you may be aware that drug-resistant TB in our setting is an emerging threat. We have a significant number of drug-resistant TB patients in our country, and this actually includes pediatric as well as adults, and it also includes people living with HIV and also HIV-negative individuals. So today I'm going to take you through on what is drug-resistant TB. Then we're going to go into how do you make a diagnosis of drug-resistant TB. Then we'll move into management of drug-resistant TB. In our presentation today, we also have some 4 questions, and also we have some discussions that we're going to have. So essentially, today's learning objectives will define what drug-resistant TB is. Then also at the end of the session, we'll look at how to identify risk factors for drug-resistant TB. Then the third objective is how you make a diagnosis of MDR TB. Essentially, here we're referring to drug-resistant TB. I'm sure in my presentation, you're going to hear the term drug-resistant TB more than MDR. The reason being is that there are other forms of drug-resistant TB other than MDR. So what you are seeing here before us is what is drug-resistant TB, commonly called as DRTB. So this is a form of tuberculosis that is caused by a bacteria, the Mycobacterium tuberculosis strain, that is resistant to one or more of the anti-TB drugs. And here we are referring essentially to the first-line drug, and also we're also referring to the second-line drug. More often than not, when we refer to drug-resistant TB, we're talking about the first-line drugs, which are rifampicin, isoniazid, ethambutol, and pyrazinamide, because these constitute our core drugs for management of TB. So I would like also just to look through the definitions that are going to help us in today's presentation. Here we're talking about that DRTB can be classified into 2 forms, and this is based on the treatment history. So number one, it can be primary drug-resistant TB. Two, it can be secondary drug-resistant TB. So by primary here, we are referring to patients who have drug-resistant TB, but they've never had TB before. So the first time they have TB, it's already drug-resistant TB. So we will learn more how this comes about. Then secondary drug-resistant TB is where an individual has suffered from TB before, and the second episode that they have is drug-resistant TB. Or a patient who is on first-line TB drugs and they develop resistance. This is what is called secondary drug-resistant TB. Also, I would also want you to appreciate the other definitions of drug-resistant TB, which are defined on the basis of drug resistance patterns. So we have what you call monoresistance. This is resistance to at least one of the core drugs. And I'm sure you've seen a lot of rifampicin resistance. That's one form of monoresistance. Then we have polyresistance, which is resistance to more than two drugs. Then MDR is resistance to at least rifampicin and isoniazid. I'm sure you've also heard about extensive drug-resistant TB. This is essentially MDR plus resistance to the fluoroquinolones and one of the injectable drugs. So essentially, this is an advanced form of drug-resistant TB. Okay, so we're moving on to what are the risk factors for drug-resistant TB. So drug-resistant TB does not come by itself. So remember, in our earlier definitions, we talked about primary drug-resistant TB, where an individual has drug-resistant TB, but they've never suffered from. So where is this coming from? So it's essentially coming from being in close contact with a drug-resistant TB. So being a family member or a household contact, a workmate to a drug-resistant TB, that in itself puts you at high risk of contracting drug-resistant TB. People living with HIV or persons living with HIV are at a high risk of contracting DRTB. The reason being is that these individuals are on a lot of drugs, and there's a lot of drug-to-drug interaction, and that in itself predisposes them to developing drug-resistant TB. And by virtue of just being HIV positive, you are at risk of contracting any form of TB, and one of that can actually be drug-resistant TB. Prisoners are at a high risk. Why are prisoners at a high risk? Because of overcrowding, and also is that the monitoring of treatment in prison setting is quite difficult. So you may have an inmate who's on first-line drugs, may not be adhering properly, and may fail. And also the other inmates who develop TB may develop a drug-resistant form. And this is why prisoners are a high risk group. Previously treated individuals, so here we're talking about individuals who have once suffered from TB and they have a relapse, or within the course of the treatment, due to underdosing or other issues, poor adherence, they develop treatment failure. And because of that, they are at high risk. Loss to follow-up, those who withdraw from care, so they are at high risk. TB drugs are meant to be taken for a period of 6 months. Any shorter period other than 6 months predisposes you to developing drug-resistant TB. So patients who are smear positive at month 2 or who remain smear positive at month 2 of the first line. So essentially, if a patient goes into month 2 and they are still smear positive or culture positive, this individual is likely to be failing the first line treatment. And by that, they are a high risk for drug-resistant TB. Healthcare workers, I'm sure you can see the last bullet there. As healthcare workers, we are at high risk of drug-resistant TB. The reason being is that the patients we are looking after, we may not know. The patients who present to the emergency room, we may not know that they have drug-resistant TB, and we may be in contact before we put in any infection control measures. So by that, healthcare workers are high risk because of exposure, high rates of exposure to drug-resistant TB, especially those who haven't been put on treatment. So we have 4 questions before us. how does primary drug-resistant TB come about? So our poll question number 1, how does primary drug resistance come about? The first choice is poor adherence. The second choice is drug interaction. The third choice being C is inappropriate dosing. And D, our last choice, close contact with a DRTB patient. So Sombo, I would like you to guide the audience on how we proceed with the poll question.
Oh, okay.
Sombo, would you guide the audience on how we proceed with the poll question?
Yes, sir. So we can go ahead and vote. How does primary TB, drug-resistant TB come about? Is it from poor adherence? B, drug interactions? C, is it inappropriate dosing? And D, is it close contact with someone with drug-resistant TB? So unfortunately, you cannot.
Yet.
We are seeing, but because you are not here with us, you cannot see how people are voting. But
okay.
So far, on A, we have 5 people that think people think poor adherence is a cause for primary drug resistance, while you have 45, which is 87% of the people in the network feel that it's close contact with someone with drug-resistant TB.
Okay.
Yeah, so we will talk about these at the end. I'm going to end the polling at this point. So you have a few more that feel it's poor adherence. No one thinks that drug interactions can lead to primary drug resistance. You have 0 people thinking it's inappropriate dosing, but you have a few people thinking poor adherence can cause primary drug resistance, and most people think it's close contact with someone who has drug-resistant TB. So Dr. Lungu will tell us the responses later. Please just try to speak up. You are a bit faint. Sorry about that.
Okay. So I'll try by all means. Maybe let me hold the mic in my hand. How does it sound?
Yes, that's better. I'm sure you can see the results now.
Okay.
Can you see them? That's how people
voted.
I
can see that 86% think it's by close contact. Do you want me to review the answer now?
No, not now. Thank you.
Okay, thanks. Are the poll closed?
Yes, sir.
Okay, thank you very much. So we will proceed with the slides being shown. So I think this now brings us to explaining how different forms of drug resistance comes about. So you have what we are calling acquired drug-resistant TB, which is also called secondary drug-resistant TB. Then we have primary drug-resistant TB. I'll start by defining what is primary drug-resistant once again. So by primary drug-resistant TB, here the take-home message is that an individual has never suffered from TB before. And the first time they suffer from TB, it's drug resistant. So what does this mean? That this individual who suffers primary drug resistant TB, he or she inhaled a bacteria that was already resistant to the TB drug. So how does that inhaling comes about? It comes by being in close contact with a drug-resistant TB, most likely living in the same household or working in the same environment or being in a bus with someone who has drug-resistant TB. So this is how it comes about. So the take-home message of the mechanism of primary drug-resistant TB is one, inhaling a bacteria that is already resistant. So an individual has never suffered from TB before. I hope now we've put things in perspective, and perhaps maybe somebody can take this opportunity to review the answer to the poll question. So the
That's
answer
fine.
there was, the answer was D. So primary drug-resistant TB comes as a result of being in close contact with a patient with drug-resistant TB. So the answer to our question is D. Then the mechanism of acquired drug-resistant TB, which is also called secondary drug-resistant TB. So here, an individual has TB, and what happens is that due to poor adherence, due to underdosing, they develop resistance. Or an individual who's developing TB for the second time, that is acquired drug. That's how drug-resistant TB comes about. I hope we are all clear. So in acquired drug-resistant TB, the take-home message is also that a person has been exposed to the TB drug. So meaning a person has taken the TB drug before. Unlike on the side of primary drug-resistant TB, they've never taken any TB drug before. So also I would also I'm sure we all remember the term mutation. So what happens is that a TB bacteria learns or adapts itself to live in an environment where there are TB drugs. So it's where replication of a TB bacteria takes place in the presence of drugs. So those bacteria that replicate in the presence of the TB drug attain a survival mechanism which we are calling resistance. So meaning no matter how much you give them the TB drug, they will not be killed or they will not respond. That's how I can explain it in simpler terms. So this is why also we emphasize on adherence to the TB drug and also patients being given the right doses. We could move to the next slide. So what are the factors that lead to development of secondary drug-resistant TB or acquired drug-resistant TB? So there are factors which are due to the healthcare worker provider. There are also drug issues. There are also patient factors. So I want to also just highlight factors from the healthcare worker side. Inappropriate guidelines, especially in the private sector. You find that more often they don't use the guidelines that have been laid down by the Ministry of Health, or a healthcare worker who has his own guidelines not far off from what the Ministry of Health has guided. So here we're talking about non-compliance with the guidelines. Issues of poor trainings. If I do not educate you properly on this Zoom, you will take the wrong message that I'm teaching you and you put it into practice. That in itself can bring about drug-resistant TB. Poorly organized or funded TB control programs, issues of stock out of drugs, that in itself can bring about drug-resistant TB. Not paying attention to the adverse effects of the drugs. You find an individual develop hearing loss or develop some rash, we ignore that and we continue. What will happen is that the patient may stop taking the drugs because they know what is giving them those adverse effects. And what will happen is that that patient will develop resistance. Also, time and again as healthcare workers, how much education do we give to our patients about their TB status? What is required, the do's and don'ts? Time and again, I think we fail in educating our patients on compliance and with the do's and don'ts. So that in itself can bring about drug resistance. Now coming to the drugs themselves, poor quality medicine and unavailability of certain drugs, stock out of drugs, things I was talking about, poor storage. All drugs are required to be kept at a certain temperature. If you expose the TB drugs to sunlight or extremes of weather, the drugs will lose their efficacy and potency. And by that, if you give those same drugs to a patient, those drugs will not be effective. Issues of wrong dosing. This also borders on also practice by us as healthcare workers. How often do we weigh patients before starting the TB drug? Most times we start the TB drugs without weighing. Most of the TB prescription, you find that you will never see any TB patient being prescribed 5 drugs. A patient who weighs 70 kg, if I ask any one of us, has any one of us ever prescribed 5 tablets of TB drugs? The answer is likely to be a no. So a patient who has a weight of 70 kg and above and has TB needs to be on at least 5 tablets of the 4 FDCs, not less than 5. Giving him or her less than 5 is underdosing. So essentially, we need to weigh, and wrong weighing or not weighing our patients is also bring about risk of development of drug-resistant TB. On the patient side, it's the issues that we already know, issues of poor adherence, lack of information, also issues of combining TB drugs with other remedies. They lower the potency. Also in settings of HIV where they have multiple drugs, they are at risk of developing drug-resistant TB. We could move to the next slide. The other issues that are related to patient issues are issues to do with substance abuse. So you find someone who abuses alcohol is less likely to adhere. And because of that, they are at risk of developing drug-resistant TB. So now that you've known the risk factors, and because you have a patient before you, and you think this person could have drug-resistant TB, what is our approach? How do we evaluate a presumed DR-TB patient? So any patient suspected to have TB is essentially a presumed DR-TB patient as well. And this is why we're emphasizing that every patient who comes, or a presumptive TB patient, should have the sputum examined by not less than a gene expert. The reason why we're saying a gene expert is because it will give us at least resistance to rifampicin. So what you're seeing before you is an evaluation of a presumed TB patient. So in all TB patients, we need to collect at least one specimen, and this specimen should be sent for gene expert. In settings where you don't have a gene expert, you could subject it to a microscopy and collect a second specimen, which you send to a gene expert site. But we are trying by all means to facilitate that every facility has a gene expert. So that's how you approach. So I'll take the arm in an event you have a presumptive TB patient and it shows that MTB detected, rifampicin resistance not detected. What do? You approach, this is susceptible TB, and you start this patient on the first line therapy. In an event you have a patient and the gene expert results come MTB detected, rifampicin resistance detected, this is a drug-resistant TB patient, and you already know that this patient has resistance to rifampicin. And 80%, I would like to share the information with all of us that 80%, more than 80% of our rifampicin-resistant TB patients are actually MDR patients, meaning they have additional resistance to other first-line drugs. And it's also a potential that this individual could actually be an XDR patient, especially those who have relapses. Okay, so essentially the next step after you have rifampicin resistance is to start the second-line treatment, but collect another specimen which you subject to what we are calling LPA. LPA stands for line probe assay. So besides the line probe assay, is that you're also going to submit the same specimen that goes for culture as well as phenotypic drug sensitivity testing. So what LPA will tell us, LPA is able to tell us about resistance to rifampicin as well as isoniazid. It also goes further to give us resistance patterns to the key second-line drugs. And here we're talking about fluoroquinolones. We're talking about levofloxacin and moxifloxacin. The line probe assay is able to inform us of the resistance pattern to these drugs. It's also able to inform us of the resistance to the injectables. Here we're no longer talking about capreomycin and kanamycin, but we're talking about amikacin. So essentially, that's the step to take. In an event, there's no further resistance to this patient, the next step to do is to continue treating this patient as a rifampicin resistant or MDR patient with the initial drug that you started the patient on. Things change in an event that there is further resistance. LPA shows that there is resistance to the fluoroquinolone. So what are you going to do? So besides the rifampicin, this patient also has resistance to the fluoroquinolone. And I think this is quite important. So you're not going to continue a patient on a regimen or a drug that the patient is resistant to. So based on the newer information that you have, is that you're going to reevaluate and adjust the treatment accordingly. You would drop off the drugs that are resistant and substitute the drug that is resistant with another key second-line drug. So perhaps you could move to the next slide. I think we're getting some feedback. So that's how we evaluate a drug-resistant TB patient. So I would like to bring to your attention the drugs that now that you have made a diagnosis of drug-resistant TB or MDR TB, how do you treat? So I want to mention to everyone that we have 3 groups of drugs. We have revised our treatment of drug-resistant TB, and these are the drugs that we are now using for treatment of drug-resistant TB. And I want you to remember 3 groups, and the 3 groups being group A, B, and C. Of the 3 groups, the 2 groups A and B are key groups. These are the groups that contain the core drugs. And the way they've been arranged in hierarchical manner. So meaning drugs in group A should be highly prioritized, followed by drugs in group B, and lastly, drugs in group C. So the drugs in group C are only brought on board if you cannot constitute a formidable regimen with the drugs from group A and B. So I'll repeat this again. The priority drugs for treatment of drug-resistant TB are drugs existing in group A and B. You only bring in drugs from group C as add-on drugs or because you could not constitute a full regimen from group A and B. And those circumstances do occur and quite rare. And the reasons why it does so happen is that you may have a patient who's resistant to the fluoroquinolone. They're not going to use the fluoroquinolone. And that patient may also be anemic. So meaning you will not use your fluoroquinolones, you will not use your linezolid. So the only drug you're remaining with is bedaquiline. So then now you have to pick drugs from group C to help and consolidate your full drug regimen for drug-resistant TB. I hope we are very clear. And the reasons why we are not prioritizing group C also, besides effectiveness, is also the issue of resistance. So what you're seeing before us is the issue of adverse effects, not resistance, sorry. So what you're seeing before us are the 3 standardized treatment regimens that have been adopted by the National TB Program. So here, we're looking at a longer regimen meaning the total duration time of treatment is 18 months. So in this regimen, I want us to focus on the first one, number 1. So here we have bedaquiline for 6 months. We also have levofloxacin, which continues for the entire duration of 18 months. We have linezolid, which also continues for the duration of 18 months. And we have clofazimine that also continues for the entire duration of 18 months. So here we have how many drugs in the first 6 months? We have 4 drugs. Then in the remaining 12 months, we reduce to only 3 drugs. So bedaquiline falls off after 6 months. There are certain exceptional circumstances where bedaquiline can exceed 6 months. You could extend bedaquiline to 9 to 12 months. In an event, a patient's culture remains positive at month 5. You're not going to stop bedaquiline at month 5. You're going to extend up to 9 to 12 months, and it's still safe. All you do is monitor the ECGs and monitor for adverse effects during that extended period. So essentially, all things being equal, it's bedaquiline for 6 months, levofloxacin for 18 months, linezolid for 18 months, and clofazimine. For the second regimen, essentially here we're just switching levofloxacin for moxifloxacin. So you could substitute levofloxacin for mox, and also you could also bring in, if you can't bring in linezolid, you could bring in cycloserine. In an event your patient is anemic, linezolid is then contraindicated. So you're going to fall back on cycloserine. So in this regimen, you are going to use bedaquiline. Sorry, let's go back to the previous slide. So you're going to fall on bedaquiline, mox or levofloxacin, clofazimine, and cycloserine, essentially 4 drugs for the first 4 months. Then after 6 months, you're going to drop off bedaquiline. Sorry, I mentioned bedaquiline for 4 months. It's 6 months. So this is our regimen. So also in an event, the last regimen that we have here is where you cannot give a fluoroquinolone. So in an event, a fluoroquinolone is resistant, or there are perceived adverse effects due to a fluoroquinolone, then you're going to use bedaquiline, linezolid, clofazimine, and cycloserine for the same duration of 18 months. So these are the 3 preferred regimens for treatment of drug-resistant TB. I'm sure you are all aware that we have the shorter treatment regimen. Before, we were using kanamycin, moxifloxacin, ethionamide, clofazimine, high-dose isoniazid, parazinamide, and ethambutol. But due to a number of adverse effects associated with kanamycin or capreomycin, we're no longer using these 2 drugs. So our shorter regimen, in the first 4 to 6 months, where there was kanamycin, we have amikacin substituted. I know there will be a lot of concerns to say amikacin and kanamycin are more brother and sister drugs with the same adverse effects. As a program, we are not advocating for these, for amikacin, but in an event we are not able to give a bedaquiline-based regimen, we'll fall back on this regimen. So we have the second regimen called the modified shorter regimen. Here, essentially, we are substituting an injectable with bedaquiline. The duration remains the same, and the other drugs remain the same. So a good number of our patients are on a modified shorter regimen, where we have just simply substituted amikacin or kanamycin with bedaquiline. Because there is little information about the modified shorter regimen, every patient put on this regimen will need to be observed very, very closely. And in these patients will be monitored for the response and also be monitored for the development of adverse effects. So these are our treatment regimens that we have. We have the longer regimen. We also have the shorter regimen. Soon enough, there may be a revision of the treatment regimen where we are going to introduce an oral bedaquiline-based regimen besides what we have shown here, which is going to prioritize the group A and B drug. I think wait for that communication. For now, don't put patients on that regimen, but we are moving in that direction. Patients with drug-resistant TB require a lot of monitoring. And the reasons for monitoring is that we're monitoring for response to therapy. We are also monitoring for development of adverse effects. So it is very important that these patients are closely monitored. Our female colleagues or our female patients need to be monitored for pregnancy. The reason being is that some of the drugs that we use for DRTB have effects on the unborn child. And also don't know some of the effects that they may have. So this is why, by all means, patients, female patients who are in the reproductive age group should be closely monitored for any signs, symptoms, or any test of pregnancy while they are on this therapy. So just to go through the tests required, remember bedaquiline has an effect on a prolongation of the QT interval. So it is for that reason that we need to ensure that before we start a patient on bedaquiline, we should at all costs exclude presence of cardiovascular disease. So besides an ECG, you may go an extra mile and do an echo in some of the patients just to see if there's any pulmonary hypertension or any existing cardiovascular disease. But to a large extent, ECG is good enough. If the ECG is normal and there's no pre-existing cardiovascular disease in that patient, start the patient on a bedaquiline base. It is very, very important that we monitor this patient. We monitor the electrolytes of this patient because some of the drugs that these patients are going to take depend a lot on the normal electrolyte balance. Bedaquiline requires that the patient has normal potassium. In an event there's low potassium, this patient, you'll be putting the patient at high risk of prolongation of the QT interval. I'll not go into much more detail what that may do. Thyroid function test is key because some of the drugs that we use have an effect on the endocrine organs, ethionamide in particular. I already mentioned about the GRAV index. So a female patient of reproductive age group should be tested for the presence for pregnancy at the beginning and during the course of the therapy. A chest X-ray is an important tool for diagnosis and monitoring. You want to see the response to therapy also using a chest X-ray, and also besides the diagnosis. Full blood count is important. Remember, we're going to use the nasal lead to a large extent in a number of our patients. Then a good number of our patients are also HIV co-infected. Besides also, those who you don't know, make sure that you test for their HIV, and if positive, do a CD4 count and viral load as required. Why are we using an initial test? Remember, these patients may be on a Sambito for a very long time, and they may develop the adverse effects due to a Sambito. Audiometry, those patients who are on injectables need to be monitored for any hearing loss of any grade. And should they develop any hearing loss, treatment should be stopped. We should monitor the patient's weight and BMI on a monthly basis. This in itself indicates response to therapy. It is mandatory that we monitor these patients' smears and culture on a monthly basis. Then also we need to know the DST. The DST guides, not only helps guide in the treatment or the drugs of choice to be used in this patient. So DST is very cardinal, and DST is done at the beginning and at any time when you suspect failure or poor response to therapy. So by doing a gene expert, we are already doing DST and DST to rifampicin. I mentioned earlier on that this patient needs to be monitored for adverse effects because any adverse effect can have a negative implication on patient treatment outcome. Some of the adverse effects, such as hearing loss, may lead to a patient abandoning treatment. And also, we need to prevent these adverse effects to a point that they actually become lifelong. So that's what I wanted to share with you on the monitoring. Monitoring is very, very cardinal. So I have one scenario for you, for all of us to work out. I want us to take 2 minutes to read through. I'll read through for you. So we have a patient called Mr. Jones. Mr. Jones is 27 years old. He is HIV negative. He presents to a clinic with symptoms of cough, chest pains, night sweats, and weight loss. He works as a taxi driver and has never suffered from TB before. An alert clinical officer or a nurse like yourself makes a presumptive diagnosis of TB. You really think this is TB. You request for expert, which is a gene expert, chest x-ray, and biochemistry. The results come back and they show that the patient has MTB detected and RIF detected, meaning the patient has TB and also rifampicin resistance. The biochemistry tests that you requested for are normal. The chest x-ray that you've done and you've reviewed, you've seen that this patient has left apical cavitation. You then refer this patient to a tertiary hospital. It could be the University Teaching Hospital, it could be Mansa General Hospital for commencement of therapy. And here we're referring to drug-resistant TB. Experts at a tertiary hospital, the healthcare worker there decides to repeat the sputum examination. And it is found that it's only MTB detected. RIF resistance is not detected. What do you think is going on? Has this ever happened before? What do you think is happening to this patient?
So
the
only allow
that we have, how will you manage this patient? So the question that we have is, how will you manage this patient? So the first answer is start first-line drugs. That means treat as susceptible TB. B, request for line from assay and wait. So meaning you're just evaluating this patient further. You're not starting the patient on treatment. C, request for culture and wait. No treatment started. D, start second-line drugs and treat this patient as drug-resistant TB.
Okay, so I'm going to share the results with you, Dr. Lungu, and you can tell us the answer. We are behind time on this discordant result. Someone had a positive and a negative. Do you wait or do you do something? So, Dr. Lungu.
Yeah, so thank you very much, Dr. Foloshi. So essentially here we're discussing discordant results. So the answer is to start the patient on the second-line drug. So what you do is rely on the side of the positive result. So what is happening in this patient is that this patient could have had a mixed infection. So there's a possibility that our patient that we are looking at is a patient who is infected with both susceptible TB as well as drug-resistant TB. So it so happens that the pocket or the lung where this specimen came from the second time, it's from a pocket where a patient has TB, but it is rifampicin sensitive. So how you are going to treat this patient, you are going to treat this patient with the second line drugs. Remember, the second line drugs are also able to treat the susceptible TB. In other settings or other experts may wish to add first line drugs to the second line drugs. But in our setting, we're just giving the second line drugs. So this example I've shared with you is an example of a discordant result. So I also want to share with you is that from the statistics that we have, 10 to 20% of patients with drug-resistant TB have discordant results, meaning they may have both susceptible or they may have, what we mean by discordant is that when you repeat the test, they either come out negative or they'll show you a different resistance pattern. This is not to say any of the two results are wrong. No. The results to be consistent on a large extent depend on the quality of sputum. So if you actually repeated an early morning sputum, which is of high quality, you are likely to get consistent results. And also if you do invasive procedures such as bronchoscopy and get specimens from different pockets or different anatomical sites, you are likely to get consistent results. So in a nutshell, discordant results occur in a rate of 10 to 20%. Is this significant? This is significant, and we are seeing this common in our clinical setting. A few individuals have been stopped on second line drugs and pushed back on the first line drugs. So we're saying that the rightful thing to do is to continue these individuals on second line drugs. If you are really in doubt, we can do other tests such as whole genome sequencing. This is the only time that we can exclude discordant results. Culture, phenotypic DST, liquid DST, or gene expert and line probe assay are unlikely to exclude discordant results. It's only when you do whole genome sequencing. We haven't reached those levels. We are still relying on the current tools that we have. So in a nutshell, take-home message, approach to discordant results. The measure is that lean on what? On the side of the positive result. So in other words, lean on the side of the worst result. So I want to share with you that 63% of patients with discordant results, when treated with first-line drugs, 63% failed at poor outcomes. And those poor outcomes constituted mortality, constituted failure, and relapses. So now, we've been engaging the last 1 hour. We've come to our take-home points. So the take-home points that I would like you to remember is that DRTB can either be primary or secondary, meaning one can get infection of DRTB even if they've never suffered from TB before. Then if they're on therapy, they're not adhering, they will develop secondary drug-resistant TB. So the second point, take-home point, is that adequate management of susceptible TB is very cardinal. Cardinal in preventing DRTB. If a patient is well supported by us, the healthcare workers and the family, and this patient successfully takes his drug, first-line drug, he will not develop drug-resistant TB. Every TB patient, be it pulmonary, extrapulmonary, should have drug susceptibility testing done. The reason being is that TB meningitis could already be resistant to rifampicin. And if you treat them as susceptible, you are likely to have a poor outcome. We have cases of extrapulmonary, that is already drug-resistant TB, and they have been successfully treated with the second-line drug. An oral drug regimen for drug-resistant TB is highly preferred. So we are no longer encouraging the kanamycin-based regimen. So those settings where you have patients on kanamycin, please reach out to us. We have bedaquiline, and we can modify the drug regimens together. We all know the adverse effects that come from kanamycin-based regimen. Patients with despondent RIF result should be treated as drug-resistant TB. So lean on the side of the worst result. Lean on the side of the positive result. It is not beneficial to repeat experts if the initial test is positive. So don't question it. We've just shared with you that a person can have primary drug-resistant TB. So I missed the last point there. Contact tracing is very, very hard. When you have drug-resistant TB patients, there's no substitute to contact tracing. Every DRTB or every TB patient, we should ensure that we do contact tracing. So these are my contact details. As mentioned earlier, I'm Dr. Lungu Patrick, and that's my phone number there, and that's my email address that you can easily reach me. I have other email addresses, but definitely to send an email to this, it will definitely reach me.
Okay, thank you so much, Dr. Lungu.
That marks the end of my presentation.
Thank you so much. It's quite a lot. We'll allow some questions from the network or contributions. I know there was one that came through that asked, what's the Ishara test?
Okay. So the Ishara test is essentially a map, or a booklet with different. Somebody, do you want me to respond to that now?
Yes, go ahead.
Yeah, so essentially a booklet or a map that is usually to assess more, not really visual acuity, but essentially we are assessing the effect of the thambute on the retina. So you find that a patient who has suffered side effects of the thambute will not be able to recognize the patterns, will not be able to recognize the numbers correctly. So it essentially detects for defects in the retina of a patient.
Yeah, so the Ishara has funny test. It's color, it's got a bit of green, a bit of orange. So it looks at your color discrimination as well. Because remember, thambute causes optic neuropathy. So does ethionamide. So let's actually ask their question. You have a lot of questions, Dr. Lungu. I'm so sorry, we'll just take a few.
No, that's
Joel.
Yes, thanks for the presentation and good afternoon. The question I have is in line with where you said if a patient has developed hearing problems, drugs should be suspended. Does it apply also on clients who've developed eyesight problem? Because in our case, we've got a client who's now having a problem where he cannot see more than 10 meters. Thank you.
Thank you very much. So essentially, when adverse effects of this nature, such as eyesight loss or hearing loss develop, identify the offending drug. So you're only going to remove the offending drug. They're not going to stop the entire regimen. So in an event someone is on a ethambutol and develops eyesight problem, you're only going to stop the ethambutol and the rest of the drugs continue. In an event someone develops hearing loss while on a kanamycin-based regimen, you're only going to stop the kanamycin and substitute with other drugs with less side effects and monitor.
Thank you so much. Mazabuka, please share your slides. Whenever you have toxicity, you need to discontinue the drug. I'm sure we saw that Dr. Lungu showed us that we have a lot of alternatives now, like bedaquiline, and that's why we are moving away from kanamycin. We are trying to go to all oral regimes with better side effect profiles. I think the take-home message is we need to cancel our TB patients, the ones with drug-susceptible TB. We need to make sure they take their drugs. We need to make sure we check for drug complex. I wouldn't advise anyone to memorize them. You can always put up job aids in your wards and always check. Don't take shortcuts with these patients because they're already in a tight spot. Mazabuka, go ahead. Dr. Chanda. Dr. Chanda, please put it as a slideshow, or do you want us to share? Where is it? So we seem to have a sound problem with Mazabuka, so we will kick off their case on their behalf. Then they'll join us because we are short of time. Then Dr. Lungu can help us. Essentially, Dr. Chanda and Kim, mentored by Dr. Simenda, they have a patient who's 50 years old and on ART since 2008. So at least 10 years on ART. They have been managing her. Mazabuka?
Yes, yes, apology.
You can pick up the case.
Yeah, you can get us.
Next slide. Yes, you can go into the history. We've already said she's 50 years old.
Okay. Sorry, just a minute. Okay, yeah. So I'll start from the first. My name is Chanda Humphrey. I'm medical officer at Mazabuka General Hospital. So as a team, we're doing a presentation for today on MDR. So we have a 50-year-old female who tested positive in 2008, and she has been on ART since then. She was referred from a local clinic, that's a Ndeke clinic, for further treatment of RR TB, which was diagnosed by gene experts. Dr. Lungu,
you can continue. We are changing your slide decks because you are sharing the old ones.
I can't see, you can't see the presentation.
Please go ahead with the presentation. It's fine.
Thank you. So she presented to our facility 2 months after initiation of ATT. By then, she was started on a longer regime, which is no longer used.
Oh,
she came with
just a presentation.
You have too many people talking in your background.
It's not us.
Okay, go ahead.
The Livingston people. So she came with complaints of chronic cough, chest pain, she had loss of appetite, and she had generalized body weakness for 2 months. This is a patient who has a history of being treated for TB in 2008, 2010, and 2014. So the time she presented to the hospital, this was the fourth episode of TB. Unfortunately, the outcomes of this treatment were not documented. We tried to follow up, but we couldn't find the reports. And the patient also had a history of missing doses. In the drug history, when she was started on ART, she was started on TOE, and on the following drugs for the longer regime, which she took for 9 months. Currently, she's in the continuation phase in month 5 now. In the social history, our client works as a bartender, or rather she used to work as a bartender, but she no longer works due to the illness. She used to take alcohol. She's never smoked, and now lives with the family. She lives with the family right now because they're taking care of her. She has 7 children from 2 previous marriages, of which she's both divorced. All the children were screened for TB. They were negative. So these children used to live with the grandmother. They were not staying with her. Unfortunately, we could not trace their husbands due to lack of contacts, and no contact tracing was done at her workplace at the time that she was diagnosed in 2018. So our client has a 28-year-old partner who used to patronize the bar for 5 years. This partner was tested positive in November last year and was started on TOD. So later on, in May, 5 months after being started on ATT, she was found to have RR, rifampicin-resistant TB, in May. So this patient was being treated for recurrent discharge on the left side of the chest, which initially the attending clinician thought was recurrent abscesses. So she was put on various antibiotics with no improvement. And 2 to 5 months later, we decided to do gene expert on the pass swab, and it was positive, yes. The patient has improved. That's a partner. On examination, on the last examination, that we saw a patient last month, the female, she was wasted. She had mild pallor and was not in respiratory distress. The height was 160 with a weight of 37 kg. The BMI was very low at 14. So this patient has the issue of losing weight once she goes home, and when we keep her in the hospital, she gains, but once she goes home, she comes back with severe or significant weight loss. Yeah. The other findings are not very significant, apart from the bilateral conscripts on chest examination. I can go to the next slide. Okay. So for the labs, there was as follows. There were a lot of labs that have been done on this patient from the time of admission. So I tried to just present the significant ones and the latest results. So the viral that was done last year, a month after she was diagnosed RRTB, the viral was not detected, and another one was repeated in March of this year. It was also undetected. The CD4 count was 384 in September last year, and in July it was 484. The gene expert that was done in August, that was the time the diagnosis was made for RRTB, was positive and was found to be rifampicin-resistant. And then the HB was as follows. So she had the anemia, 6.3, 7.4, and 7.7. Sorry for that. Yes. Then the urea that was done in August 2 months ago was normal. The creatine was 110. When we calculated the creatine clearance from this, it was found to be 31. Yes, 31. That's the creatine clearance. The LT was 2.2, ST 20.2. ESR that was done in February was 120 millimeters per hour. Sorry for that, it's not showing here, but it's 120. Yes. For the sputum, the one that was done in March, there was AFB seen. Then the subsequent AFB results showed no acid fast bacteria were seen. The first sample that was taken for culture in April, unfortunately the sample was said to be contaminated, so we didn't get any results. Then another one was done, sent. Mycobacterium TB was isolated, and the third one in August, unfortunately again was said to be contaminated. Next. Yes. So I don't know. We should go this one. Ask questions. Yeah. Okay. So these are our questions. after this presentation. So the patient has been in and out of hospital from August last year. We have observed that the patient has shown minimal clinical improvement despite being on treatment for 14 months. So it's a patient who is remaining with 6 months on a longer regime. So while on the treatment, of note is that she developed hearing loss at month 5 of treatment, and currently she has problems with hearing. Our first question to the network is, what further course of management should we institute to improve the outcome for this patient? Yeah.
Ask all your questions, we proceed. Remember, we are going into breakout rooms, so they'll be dealt with there.
Oh, okay, all right. Then the second question is, how can you improve service delivery to MDR patients, such as our patient here, who lives very far? Our patient is coming from Chikankata, so there's the issue of distance. Then number 3, how can you improve on the turnaround time for samples that we send to different laboratories for investigations, such as LPA in our MDR patients? Here at our facility, the normal turnaround time is about 3 months, so this poses as an hindrance to management.
Thank you so much. I'm free. Yes. You have 3 questions up there, and you have asked them. So I think, Dr. Lungu, I hope you've taken note of the case, but Macha is asking, was MTB isolated or not isolated? Because you seemed to say isolated, but here we have not isolated.
On culture?
Yes.
Yeah. So this diagnosis was made by a gene expert. So when culture was done, the first one, it was sent back as contaminated. Then the second culture that was done, was after the patient was already on 6 months on treatment.
Did they isolate or not isolate?
No, not isolated.
Not isolated. So that's your correction, Macha. I'll quickly summarize this case. Essentially, it's a 50-year-old woman on ART for more than 10 years. Her HIV is controlled. Unfortunately, this woman has gone to develop what looks like a secondary drug-resistant TB, as evidenced by her poor adherence to her first-line treatment on 3 occasions. She went on to have a partner who subsequently developed TB, what looks like an acquired drug-resistant TB, because that was the first treatment, and he presented with empyema. On examination, she's underweight with a BMI of 14. She only has a creatinine clearance of 31, and she still has basal crepe, so she's very thin. And the man is about half her age, so clearly it hasn't stopped her in her tracks. The husband, the partner seems to be doing well, she doesn't, and there are issues of distance. So they're asking the network, how can we manage these patients? As for the partner, how can we continue his good management? How can we improve service delivery when issues of distance have come in? She lives in Chikankata, I believe. And how can they improve their turnaround time? Is this something that's within their control? Because their LPA haven't come back, some of their samples have been contaminated. Do you have any questions from the network before we go into our breakout rooms? So there's a question for you, Humphrey. Where in Chikankata is the patient coming from?
Nadezwe.
Nadezwe.
Now, beds were patients, you know the patient. Anyway, Dr. Lungu, do you have any questions before we break out? Because Humphrey may end up in another room before we sort the questions out. Because this patient, she's a bartender, remember? Remember, contact tracing was not done. I'm not sure how easy it is to do a contact tracing on someone who's a bartender. She has a lot of contacts, and remember, Dr. Lungu told us you can get primary drug resistance from anywhere, and she's a very good example of that. Any other questions in the network, Chatonda? I'm seeing Yeta District, that's Chipashan Tim and Gerard. Please go ahead, you've been unmuted.
Good afternoon. We would like to know when exactly she stopped working at the bar. After how long on treatment did she stop working there?
Humphrey.
Yeah, so remember this is a patient who's been treated for TB for the first time. So while for the previous 3 treatments, she was still working. She only stopped after the 4th episode. That was around August last year. Yes.
She's hardcore. So after the 4th episode, so she's definitely managed to give a couple of people some drug-resistant TB out there. Dr. Lungu, do you have any comment before we go into the group?
Hello, Dr. Foloshi.
Yes,
yeah,
Patrick.
So for me, I have a question for the team that has just presented this case. I think also just to begin with, I would like also just to commend them for having sort of drug-resistant TB in the partner. I think they did very well on that issue. So my question goes to the team to say, when you examine the patient, was there any finger clubbing in this patient? Because it may help just start putting things in perspective. I don't know if the team can respond.
Humphrey.
I don't know at what point you'd like me to just comment on this case.
You will in a second. Humphrey, was there any clubbing in your patient? That is curving of the fingernails.
Thank you for your reminder, Dr. Foloshi. So I'm guessing I'm thinking of looking for complications of TB such as bronchiectasis. We did look for that, and there was pallor and the spooning, but there was no finger clubbing.
So there was pallor and spooning of the nails. Remember that she's not holding her HB. It's around 7. So we'll go into the breakout rooms, Chatonda, and we'll allow, how long, Dr. Tamakupe? We'll allow 20 minutes in the breakout rooms to discuss the case. Yeah. Thanks so much, Humphrey. It's very rich, this case. But I don't think any drug-resistant TB patient is easy, unfortunately. Sorry, we lost our prompt. It came. This is not where you want to be, managing a drug-resistant patient. So we can all go ahead and click and join the breakout rooms. We are going to 3 with Dr. Lungu, as we are going. So close. Yes, James, go ahead.
Hi, Doc. How are you?
I'm okay.
Yes, I wanted to, my concern was with the contamination of the samples. I don't know how they're being handled, and I know sometimes there's a bit of frustrations that may come with the patient when they have to resubmit and resubmit samples. So I don't know at what point they were getting contaminated and how we could probably manage that in maybe better sample handling. Yeah.
Okay. So Dr. Jansa is saying essentially turnaround time is the responsibility of us who collect samples to do it carefully and responsibly and the lab. So if one fails, then your turnaround time will suffer. If your sample is contaminated, it may even be discarded. But I know they can go ahead and do LPA, but they may not culture because you may end up growing all sorts of things. But let's ask Dr. Lungu about that. He's asking about the contamination. Dr. Lungu, do you want to help us?
Yeah, thank you very much, Dr. Koloshi and Jay Chansa. So essentially, contamination in this context is coming as a result of delay in submitting the sputum from the time the patient submits the sputum to the time the specimen reaches the lab. What happens is that if you take longer, the TB bacteria will die, and the normal flora is going to multiply and outgrow the TB. So that's the contamination. So essentially here, what the contamination is telling us is that this specimen reached the lab took longer to take to reach the lab. And also the specimen was not kept in a very conducive environment as they were transporting the specimen. So one of the things that is required to ensure that the TB bacteria does not die is to transport the specimens under ice in a cooler box. So essentially what this is telling us is that the specimen took longer to reach the lab, and also we did not handle the specimen transportation very, very well. So what is required? PD transportation and transporting the specimens on ice.
Thank you so much. Dr. Lungu, do you want to tell us, you say they shouldn't delay. What is timely?
Yeah, so what should happen is that if they are transporting with the specimen on ice, within 4 days, this specimen should be processed. So within 2 to 4 days, it should reach the lab. From the time the specimen is collected to the time the specimen reaches the lab, at least within that time period.
Okay. So what is your comment on a turnaround time of 3 months? What is the turnaround time that we should expect?
Yeah, so the turnaround time for culture, the minimum you could receive your results for culture is 6 weeks. So the turnaround time essentially is 6 weeks to 8 weeks. So you should get your results from the time of submitting it within 2 months. So one of the things that we know there are teething problems with our culture facilities. So one of the things that you could also do out there is reach out to us when your specimens are taking long. Then we can, on your behalf, we can reach out to the CTA or UPH lab if you are having communication channels. Otherwise, using the provincial structures, you should be able to get your specimen results in good time. Otherwise, the turnaround for culture is 6 weeks to 8 weeks. And LPA, the turnaround time is 4 days.
And the sputum is negative as well. But for this patient, we are still struggling even to get a good culture negative. So even our management in terms of diagnosis, we also need to strengthen that aspect so that we can label this woman as having seroconverted, that she no longer is actively giving out the sputum that is that she has been cleared off with the sputum. Then for the other clinical outcomes that the patient's probably currently experiencing, This one requires also an expert opinion. So we only have 1 minute before we go back to we haven't even discussed the whole thing. Sorry about that. So I'll move on to the next question. How can we improve service delivery to MDR patients who live far from host facility and have challenges of transport for the monthly reviews? This one I would have loved to hear from some of our network, but we don't have enough time. So I think we'll discuss this question in the main group. The third question is, how can we improve on the turnaround time for our samples sent to referral laboratories investigations, such as for these particular tests, the urine tests, and then also the resistant tests for these patients. So these are some of the questions that I think we want to hear from the hub teams and the National TB Program itself. So I think for now, let us just prepare ourselves to move on to the main hub. But as I was saying, in terms of clinical improvement for this patient, we would need to actually find out a bit more on some of the clinical state of the patient, because already we're looking at the creatinine and clearance, which is very low. The body mass index is very low. So there's a lot of nutritional support that needs to be supported. This patient is also malnourished. So that has also taken a toll on her as well. And so even if maybe the patient may have been treated with MDR TB drugs, but I think still is lacking in terms of other supportive care, such as nutrition and the other things. So unless there are any other comments from the hub, the network, before we move on to go back.
Hello?
Yes, please go ahead. Yeah?
Especially when it comes to TB drugs. Really never, ever, ever just take anything. You need to always check your drug interaction checker. So something interesting has come to here, Dr. Katamba and my lovely students from St. Luke's. Yes, Shaheen, do you want to talk about what you said?
So the main worry about DTG is with rifampicin interaction, which is why we double dose. Now our patient is already on second line. TB medications, so there's no need to double dose the DTG.
Okay, so he's saying we don't need to double dose because there's no rifampicin. What's your comment on the TAF, the tenofovir alafenamide?
Well, to my knowledge, I might be mistaken, but I don't think it's contraindicated in TB. I have to go through that. I would like.
In here, so even the TAF is okay to use, but the students are very correct. We do not recommend TAF in patients who are on ATT because we know it's part of the backbone of the first line. So they are very right for that. And Dr. Katamba is right to say double dose. But in this case, we don't have the devil in the room. There's no rifampicin. So a good old TAF should be able to work, but I'm sure the experts will advise us. Dr. Lungu will go back into the rooms and then you will be able to comment on the things that people say. Then I'll summarize. Is that okay? Because you hear a lot of things, then you can comment. Can we go back, please?
It's counting down.
Oh, it's counting down. Oh, we had the St. Luke's team. They are tough. They are very tough. Good afternoon, everyone. We are back in our rooms. We'll allow the team from Dr. Zico or Dr. Kozia.
That? Okay, so from our team, we identified a number of problems. The first being that this patient has had TB for the past, has been treated for TB for 4 times and now currently on MDR treatment without improvement. And we are questioning the adherence in this patient. So we are thinking she's at high risk of now proceeding to developing XDR TB, and that is something that we need to investigate for. But we are also worried that she could have post-TB sequelae, and that this patient probably may not really be deteriorating or not improving because of active TB, but because of TB complications on the lungs, such as bronchiectasis and progressive lung fibrosis. And we also took note of the fact that she isn't doing too well with regard to her HB and her weight. And so there could be a factor of malnutrition in this patient, which needs to be sorted out. We could have micronutrient deficiencies and so on. But we also took note of the toxicities that the patient has, such as neurotoxicity as well as ototoxicity from the previous drugs, such as the injectable aminoglycosides. And these are things that need to be sorted out. So with regard to the interventions that can be done, firstly, we noted that the samples that were taken to the lab were contaminated. And so we need to optimize sample collection as well as transportation. And we need to take these samples to the lab with proper supervision so that we can really see what kind of resistant pattern that this patient has. We also need to handle her in a tertiary hospital and have a CT scan done to evaluate for TB, post-TB sequelae or complications, and also engage a pulmonologist and the infectious disease team in management of the patient. We also need to enhance adherence, optimize nutrition, as well as renal treatment. We note that she is also on TDF-based regimen, and so we would need to discontinue the TDF and replace with either TAF or Abacava. And with regard to the hearing, we can engage the ENT for possible hearing aid or other interventions. So in a nutshell, that's what we talked about. We didn't discuss the other questions, but if you would want me to do that, I can do that.
Okay, thank you so much, Dr. Zico. Let's check the other room in case they did.
So Dr. Sambo, yeah, so what we did is that we split. Room 3 was covered by Zico and I covered room 2. So basically, I think we also managed to bring out issues that we thought were not really managed properly in this client. And that one of them is being the documentation. Documentation has a bearing on how we would have actually, when we would have detected the resistant TB. And so that's something that going forward, we recommend that there's strengthening documentation at your facility level. Further, I think Zico's team did actually address the issue of contamination. And we feel that this as well has a bearing on us deciding whether this patient has responded or not. Once we get a culture, we'll be able to see whether really we're dealing with an XDR or MDR or has responded. And so taking care of this issue also will be quite significant. Then we also felt that there's need for nutritional support, as the other team has suggested. And so a few of the other things that have been highlighted, like the creatinine and switching, also we discussed that. And also Now, and also malnutrition issues, we also brought that up as well, that we need to address that. Then regarding the second question, at least we had experience that was shared by Chikankata. They say that one of the things is to get the DHO involved in providing transport and providing, making sure that visits by the peer teams are made for this type of patients, so that they're able to be supported. And particularly this patient requires quite a bit of social support, looking at the way that she's come out of 2 marriages and currently in some sort of relationship. So it requires a bit of support as well in terms of social and psychosocial and counseling area. And so the peer supporters might be very helpful in that area. We did not address the third question because we are relying on Dr. Lungu and Ting, because that's a more logistical question, and I think we really want to hear from them as well. Thank you.
Thank you so much, Kozi and Dr. Zico. So essentially, we also discussed the same things. We were concerned she had 2 contaminated samples on 2 occasions. We agree, the documentation and the feedback. Because once you have a contaminated sample, it means you need to go and educate the facility. There is a problem. You should not be having recurrent contaminated samples. It's an inconvenience for the patient. And I know we had the contribution from Matero that recommended we also do DSD and culture. I think one of the things that really came out for this patient is what we can do where she is in Southern Province, is that we need to improve our social status. We need to engage our social community health care workers to see how's the living condition. How can we help her with a food parcel and maybe some monetary benefits? I know Dr. Lungu will elaborate how the MDR TB program, the incentives that are there for patients. But something interesting came up. They said that there are some church services within that area in Chikankata that may be able to help this lady, and we need to consider some home-based care with decentralization of dispensation of drugs. The other thing we discussed was the turnaround time is one, timely delivery of the samples to the lab. We were advised that they need to get there within 2 to 4 days. If it gets there later, that's why you're having the contamination. And also it should be transported in a cooler box, and we had the contribution that we really need to look into these transport mechanisms, because it's very clear they are failing. That's why this lady is ending up with contaminated samples. The lab has also been encouraged, I don't know if Dr. Lungu will elaborate, to form linkages so that when they get a result, it doesn't take 3 months to get to the facility, so that the facility can ask for it. As for the switch in drugs, we strongly agreed to go with just Tafed. We would not encourage Abacavir just because of the pill burden. She's already struggling. To add 3 pills when she was on 1, we feel would be a disadvantage. So we'd go for Tafed. So Dr. Lungu, in a nutshell.
Yeah, thank you very much, everyone, for the clear discussion. We have a different thought process from this end. And our different thought process is that if you look at the patient smears, they are all negative. So meaning the MDR regimen that this patient is likely to be effective. Why we are saying that this patient is not responding to therapy, there are comorbid conditions that this patient has. Number 1, that this patient has severe malnutrition. Number 2, this patient has renal failure, going by a creatine clearance. Then also we cannot exclude, in as much as there's no finger clubbing, but if you look at what the patient has, 9 months into treatment, this patient has cost creep. There's a very high likelihood that this patient has bronchiectasis. And that in itself can explain the wasting that this patient is having. So going by the smears that we have, highly unlikely that this patient is failing to clear the TB bacteria. But however, the most objective way of excluding that is doing culture. And this is why we should do it now, so that we exclude any form of or amplified resistance in these patients. So coming into the management of these patients, to optimize our care, let's take care of our nutritional needs. This patient needs high protein and carbohydrate diet. At the same time, this patient needs to continue on anti-TB medicine. Then also, as discussed, we need to revise our ART regimen going into TAP. The home-based care is highly required. This is a patient who is severely malnourished and cannot walk to any nearby health center. So these patients need to be linked to the home-based care services. One of the things that we have done for MDR is that we are providing nutritional support. All MDR patients are getting a family ration, and also they're getting transport refund. A patient like this one requires a nurse to be attached to look after this patient. And I know Chikankata has MDR nurses. So this is one of the patients that needs to be linked to MDR nurse, so that every day there's a healthcare worker that supervises the treatment. So these are the things that I would recommend that we do for this patient. As with regards to courier of specimen, we are dealing with one patient, but split between two programs. We are aware that the HIV program has a very robust specimen courier transport system. So why can this patient ride on that platform, which is readily available? So what we are asking the people in Chikankata is that using the current mechanism for HIV, use them to transport a specimen to either UTH or the chest diseases laboratory for culture and line from acid. So I think that's the guidance that I would like you to give. And also let's utilize our laboratory personnel at our facilities to help us establish linkage with the chest disease laboratories. Where you have difficulties, we can come in and help facilitate that. I just shared my contact, both email and phone number. So please reach out on this page and also update us whether you are having challenges with nutritional support. Thank you.
Thank you so much, Dr. Lungu. I don't know if Humphrey is still with us. First of all, well done. It really brought out a lot of TB issues without us going into, you know how TB gets very complicated, especially if it's the social issues are the big deal when it comes to rifampicin with drug-resistant TB. Essentially, you need to continue the treatment. The AFB is reassuring but not conclusive. You still need to do your DSD and culture, even if the fact that it's negative is a good sign. So you're doing something right. Nutrition-wise, the family can receive a ration, and for transport, she's entitled to a transport refund. We've been encouraged to get in touch with the lab so that we improve linkages and feedback. For the renal, you change that to TAFED, and I think it looks like your patient has complications, most likely things like bronchiectasis as evidenced by your crackles. We'll let Humphrey, how are those recommendations? Do we still have Mazabuka?
Yes, we're here.
What do you think of those recommendations? Stressful, helpful?
Both. Anyway, they're very helpful. So we only hope when you follow up, especially maybe on things like the TAFED, we'll be able to be assisted with the drugs.
Oh, I thought the TAFED was the least stressful, because TAFED is available, you can just order it from the province.
Okay, all right. So yeah, they're very nice recommendations, and we'll put them into practice.
Thank you so much, Humphrey. That's a difficult case to put together, but you did it so well. It was very easy to follow. And thank you so much, Dr. Lungu. Congratulations. They say that they are very nice recommendations. So they are very grateful.
You're welcome.
Yeah, so thank you so much. I think, what's the topic for next week? So the topic for next week is we are dealing with some of the drug toxicities that come with MDR TB. So we'll sort of be hovering around the same topic. We are taking it in pieces because clearly it's very complicated. Thank you so much for all that joined the session. And I hope we can do better for those drug susceptible TBs, because when it gets to resistance, it's a whole new ballgame. It's not a walk in the park at all. It's very hardcore stuff. So thank you. We'll see you next Monday.